So, as usual, we're going to start with a case, and I see Chris is right in front of me. So, why don't you take this case? It's a 27-year-old male. He's a wheelchair basketball player. Chief complaint is unwell. All we really know is day history, kind of sweaty, some palpitations, nauseous, no vomiting, a little bit of a headache. Past medical history as a T2 spinal cord injury and MBC, no meds, no allergies, socials, non-contributory. And these are the vitals. Interpret those. Tell me what you're thinking so far.
So he's a young gentleman, T2 injury, temperature of 378, febrile, blood pressure still okay, 130/85, satting well. Respirate's a little elevated, but given the presentation of diaphoresis and things like that with the T2 spinal cord, I wonder, is this person at risk for autonomic dysreflexia? Given his febrile nature, I'd probably go looking for sources of infection. Sure. In this gentleman, likely urinary tract infection, or especially if he has an indwelling folio or something like that. Yeah. So that's probably what he could be looking for first. Probably do some basic blood work. And
okay. So first you examine the patient. It's alert. TCS 15. Cardiac exam normal. Resp exam pretty normal. GI soft. Vital sounds are normal. CNS wise, normal irritation of the neck, no meningismus. Anything concerning there?
Not from what you said.
I agree. Blood work. Anything?
Elevated white count of 12.4, mildly elevated. This type of treatment at 129. Also, he's got a metabolic acidosis. And also respiratory alkalosis. Probably in compensation for that.
Okay. So anything concerning? What else do you want to do? You already said look for the urine, so we'll get a chest x-ray as well. Just part of the workup, nothing on that. EKG was normal sinus. Urine, 15 loops, no blood, no nitrates, and it was a CAT sample. He was having inline fully.
Probably send it for urine culture as well. It's not just urinalysis. The male patient, I know he has an indwelling foley, but 15 loops is, that's kind of suspicious. He says his belly was non-tender and it was, canvas.
So is 15 loops not normal in someone with this presentation with a cath, with an indwelling cath? Could it be normal?
Could be normal, but it could be abnormal.
What's that?
Could be abnormal.
It could be abnormal. Fair enough. All right, so you go on. You haven't really found anything yet. So, like I said, indwelling catheter. Something you want to do is roll the patient, rule out any sacral ulcers, no obvious cellulitis anywhere. So you have your investigations. You said you want to send a urine culture. What else do you want to do?
Well, he's a febrile patient. Haven't found a true source yet. In terms of
Investigations, disposition. Give him some Tylenol, send him home.
No, in this patient, I think he's especially because T2 cord injury. He's at risk for an infectious process that he can't actually localize. So I would probably treat him with antibiotics. And I wouldn't send him home. I'd have to find a source for his fever.
Okay, probably not unreasonable. So there's a few things I had up here. Give him IV fluids, antibiotics, Tylenol, discharge him. Doesn't sound like you discharge them. Probably a good idea, A, because it's grand rounds, and you probably shouldn't discharge this patient without knowing what's going on. So I think I've tortured Chris enough so he can relax for the rest of the day, at least until core. We're going to back up a little bit and I'm going to just talk about some background with disabled athletes. So everyone knows who this is, and Rick Hansen, the Man in Motion, as well as probably our most famous disabled athlete from Canada, Terry Fox. And everyone's the newest famous world disabled athlete, the Blade Runner from South Africa. This gentleman that made some headlines this year in the Summer Olympics, running the 400 meters and the 400 meter relay, I believe. Didn't medal or anything, but it was kind of interesting. And the ironic thing is that he was fighting with the IOC to get into the Olympics, and saying that competitors were saying that his blades actually gave him an advantage in the Paralympics following the regular Olympics. He made a comment about someone who beat him in the race, saying that his blades are longer, and he had an unfair advantage, which he subsequently apologized for, but just some kind of off-the-cuff remarks that weren't well thought through. This is obviously a very busy slide. This is just meant to illustrate what's going on. So before Oscar, there were many athletes who were disabled who competed in the Olympics. I'm just going to point out a few of these. One I find really interesting is the top one, 1904. George Eisers, an American gymnast, actually won 3 gold medals. The vault, parallel bars, and apparently rope climbing was an Olympic event back in the day. But he won those with a wooden leg after a train accident. I can see the rope climbing, but the vault with a wooden leg, that's impressive. There's a few more in here. Water polo in the 20s and 30s. Person with the left leg amputee. There was a pistol shooter in the 40s and 50s who was in the war and badly injured his right hand, his shooting hand, and he trained himself to shoot with his left hand. Actually won gold 48 and 52 Olympics. What's that one up there? So it's a deaf swimmer. There was 1984 New Zealand archer, paralyzed from the waist down, participated in a wheelchair in both the Paralympics and the Olympic Games. And this is the second list of more recent people. So there's a South African swimmer who was deaf, a runner who's legally blind from the U.S. Thought this was interesting. 2008 South African swimmer, open water 10K, who's also a left leg amputee and came in 16th. I wouldn't be able to even finish the race, but good for her. Was an archer who was legally blind that won a gold medal in the team competition in 2004, 2008. So lots of disabled athletes have competed in both over the years, and I didn't know that. I'm sure most people weren't aware of this. So just some more background. The Paralympics have grown from a small gathering of World War II veterans in 1848. That's where it started. And the term Paralympics actually derived from this Greek preposition, which means beside or alongside, not actually referring to paraplegic, which is probably the biggest common misconception. And back in, I think it was the 50s when they started, they were actually calling themselves the Paralympic Games. And the Olympics didn't like that at the time, so they shortened it to Paralympic, and now they're held in tandem. The Summer Games in Seoul in '88 were the first official Paralympics, and there's also the Special Olympics and the Deaf Olympics, which are separate entities altogether. There's 6 categories that people can compete in the Paralympics, 6 broad categories. First one's being amputee, cerebral palsy, intellectual disability, wheelchair, visually impaired, and then the others, who are dwarfism, MS, and congenital disorders. So, all athletes are at risk for medical problems in any can be a competition that they go into. They're at risk for dehydration, heat illness, heat stroke, depending on where you're practicing, fractures, lags, ligamentous tendon injuries, asthma, concussion, the list goes on and on and on and on. But medical problems with disabled athletes, they're at risk for all of those. Plus, they have an underlying condition that they would be at risk for other injuries, other conditions. Let's see, Natalie, what specific conditions would disabled athletes be at risk for over and above able-bodied athletes? Anything you can think of?
So I guess things like UTIs, skin infections, ulcers.
Regular athletes can't get UTIs and skin infections.
They
You know what goes on in the Olympic Village?
they certainly can, but probably at, I think, at less of a risk. I don't have any evidence to support that. I guess any intra-abdominal pathology, if for somebody like the previous patient, just potentially because you don't have the sensation, you may not feel pain, if you have a grumbling appendicitis, and things might, just get a little further than they might have otherwise. I can't really think of anything else specifically.
Anything else? Doran, hiding in the back.
I don't know. I don't think I pushed one of that Chris already mentioned.
Okay. Going up the years here. Kate.
The only other thing that comes to mind is things related, like the regulations around medications and medication effects probably are different. So probably lots of other drug interactions and drugs combined with sort of hypothermia and excessive training, hypoglycemia, those sorts of things may be more common.
Sure. All right, so we're going to go through a few individual things here. So the first one's going to be impaired thermoregulation, which I think Kate alluded to up there. So specifically people with spinal cord injury and specifically above T8. These people have problems with their sympathetic nervous system. So basically they just can't get the output because the spinal cord is injured in that area. So increased risk for both heat and cold-related illnesses. They may not sweat effectively, or they may have vasodilation at below the level of the injury. So this impairs the body ability to either cool itself or warm itself through shivering. And who would be at risk for this sort of thing? Morgan? I don't know where you are. Here you are. Who? So. Sorry, I said who would be at risk. I rephrased the question. Why would an amputee be at risk for this?
For impaired thermoregulation?
Yes. Think about pediatrics.
In terms of like surface area drugs?
Yeah.
We're going to have reduced surface area,
Exactly.
so there's going to be less of an ability to actually dissipate.
Yeah. That's exactly right. So everyone heard that's a decreased body surface area, so they have decreased ability to cool or warm themselves based on whatever the situation is. What about medications? What medications would put you at risk? Gonna make me pick on someone? Can I pick on Coon next year?
Don't pick on me.
All right. Do I talk to my own ear? Thank you.
So anticholinergics.
Absolutely. Go on.
Something cardiovascular. Like cardiovascular drugs if they needed.
Such as? Am I being too hard?
Sorry?
I said such as.
Like your beta blockers.
Absolutely.
Your channel blockers.
Yep.
Your vasodilatory medications.
Yep. Those are some of them. So the list I have is not inclusive, but anticholinergics, neuroleptics as well would interfere with this. Anytime you say anticholinergics, you can pretty much say antihistamines on any answer. So antihistamines, diuretics are also in that, beta blockers, thyroid medications, muscle relaxants. For some reason, if they're taking some pathomimetics, can do it as well.
Yeah, I have a question about that.
Yeah.
Do the Paralympics and Parasport have their own WADA regulations?
I'm going to get to that later. So, thank you for the primer. A little wait with bated breath. What else are people at risk for? Pressure ulcers, obviously. They're common, they're preventable. Often athletes, spinal cord injuries will get these. So it's unrelieved pressure over an area, leads to skin breakdown, skin necrosis, cell death. The incidence with spinal cord injury is thought to be 30% 5 years post-injury. That's not specific to athletes, that's all comers. Key factors, level of the injury, how long they're in the chair, duration, tissue tolerance. Some other reasons why they would get ulcers specific to athletes, that they're in their chair a long time between events. The chairs are designed not for comfort, but more for speed, being light, aerodynamic, to help them in their competition. So these factors would be more likely to cause irritation. They're usually not wearing their typical clothing, it's kind of lighter, thinner, and obviously sweating is a key issue with this as well. Sacrum, as you might expect, is the most common site of severe pressure ulcers. Other areas, hip, buttocks, heels. Complications, cellulitis, sepsis, osteomyelitis, septic arthritis, depending on where it is. The next thing we're going to talk about is hydrocephalus. Depending on, again, this is kind of all broad categories. There's probably hundreds of medical conditions that we can talk about that would put you at risk in these events, but I just highlighted some of the bigger ones. Hydrocephalus, so people may have a shunt, and that shunt may be at risk secondary to trauma. So if someone with the VP shunt gets hit in the head during an event, do they have a concussion? Do they have a bleed? Is their shunt damaged? I don't know. That's going to be a really tough call. I can't say I've ever actually seen a patient with a shunt that had a head injury in sports, but that I think would be very difficult to sort through what's going on with that patient, and you may not be able to right away. It's maybe something that you may have to give good discharge instructions to. If it's a concussion, it's going to be this. Obviously, you want to rule out a bleed, but shunt damage, you may not see that right away. So they come back a few days later, and their ventricles are huge. Next thing, osteoporosis. I know emerge docs really care a lot about osteoporosis, but we should in this patient population when it comes in, because basically they're going to be a higher risk for fractures. So prolonged immobility decreases bone mineral density, osteoporosis, osteopenia results. So minimal trauma, just falling out of the chair, basketball, that can, or an impact, that can cause a fracture. So you should have a higher index of suspicion for fractures in this patient population, especially if there's an injury and they can't tell you if it hurts or not. That's something you really have to watch out for. Overuse shoulder injuries is the next one. That's obviously very common in wheelchair athletes, and as you might expect, that's what they're using to roll themselves around. Other factors, scoliosis, poor seating position, muscle imbalances, those can all contribute to these injuries as well. And seizures, as you might expect, a lot of these athletes would have an underlying seizure disorder, the cerebral palsy, head injury patients, and seizures can be precipitated in able-bodied athletes by sports, so we have to be very careful with these. Factors like dehydration, stress, hypoglycemia, Kate mentioned, hyperventilation, very at risk for electrolyte imbalances, and something I didn't put on the list but should be there is trauma, obviously, sporting competitions. So, next I have a mini case, and Meg, looks like you want to do this one. So, say 24-year-old female, wheelchair archer, a history of a T5 spinal cord injury. So you're on neurology now, so you should be able to work through this. So chief complaint is confusion. Medications we have there, Senecod, PRM Gravol, baclofen pump for their spasticity. Those are your vitals. Any problems with those?
Yes.
And are any of them okay?
So she's starting up.
Yeah.
It's just so confusions are very broad differential. I guess you could go through a vitamin C differential for that. Her medications alone could give her confusion. She obviously has something going on physiologically, fever, tachycardia, hypertension. So I would take a history and see what's changed recently, or if she has any other neurologic symptoms.
She can't really give you much, and she was kind of just sent in, so we don't have any viral history yet.
Well, I would try and call like family or talk to the paramedic.
They're not home.
The paramedic.
They don't know anything. She's confused, and those are the vitals.
So she'll probably get well, okay, I'll examine
Just,
her.
yeah, there you go. You'll get used to this. This is what happens.
Go her physical exam.
Sure. Computer's going slow. Here's your physical exam.
Is she always fasting?
It's baclofen pump.
Well, she'll probably get a full workup for fever, so like she'll get pan cultured and chest X-ray and urine and blood cultures, and probably I'd like to find a source for her fever. I'm certainly worried about things like meningitis or encephalitis or like central nervous system infections.
Yeah.
So.
Absolutely. So what do you want to do? You've done septic workup. How do you want to treat?
Did anything come back that would point to focus of infection?
Are you going to wait?
Pardon me?
Are you going to wait in this patient?
Well, I would do including a lumbar puncture, but I wouldn't delay the lumbar puncture, but I'd hopefully do it right away and then start antibiotics.
Okay. Yeah, sounds fair. So I think that's what I would do in this case as well. This person clearly at this point looks like they have an infectious process going on. Certainly at risk for that. So you want to get treatment going early, pan culture, get IV antibiotics going. Unfortunately, they have baclofen withdrawal syndrome. So this is something interesting that came across in the literature. So the baclofen pump they have to treat their spasticity. Baclofen's a GABA agonist. Comes either in pump, which goes intrathecal, or in oral form. So anyone with an abrupt change in mental status, together with other symptoms, increased spasticity, pruritus, hyperthermia, myoclonus, seizure, all those things, you really have to think about this. Hallucinations are common. I know this isn't something obviously we see or probably anyone has ever seen, but the baclofen pump, you have to be aware of it. Talked to my wife as a pharmacist at the hospital, and she says that there's about 4 or 5 patients at each site that have baclofen pumps. So it's certainly something that we could see in the future. I'm not sure if any of them are actually athletes or not. I didn't go into that, but something we definitely could see. So like I said, I think the septic workup is absolutely valid, IV antibiotics. When I asked about medications, check the pump if applicable. What's supposed to happen is the pump should alarm if there's a problem. But if the batteries died, I'm not sure what happened with that. Also, if they're vomiting, they may not be getting the oral dose, and that further complicates the medical picture. Do they have an infection and they're vomiting, or do they have gastro and then they have baclofen withdrawal syndrome? So the treatment is you treat with benzos and baclofen, obviously. Is there any ultrasound-guided intrathecal baclofen injections? Can we do that yet? Any?
Sure, why not?
All right, so I probably do PO if I want to get them stop vomiting first. Treat with benzo, I already said that. So the supply of the pump usually lasts 6 to 8 weeks, according to my wife, and it's maintained by the neurologist. So this is what it looks like. So the catheter, or the pump is intra-abdominal, catheter runs back to the spinal cord, intrathecal here. Looks like this, and then it goes under the skin here, and medication is put in through the skin, much the same way a portic cath is accessed.
They're right, like you said, like I've seen patients that emerge with these,
Yeah.
unrelated to athletes. They're certainly not related
Yeah.
in the disabled
Sure.
athlete, but they certainly show up and emerge
Absolutely.
unrelated to athletic events as well. So.
Yeah. Questions about these? No? Okay, so something else that's quite interesting. It's rare, it's poorly understood, exercise-induced anaphylaxis or angioedema. So there's 500 cases in the literature, kind of situational dependent. So you have shellfish, go for a run, then you get anaphylaxis. But if you have shellfish, unlike me obviously, but if you just have shellfish, then you don't get anaphylaxis. So just kind of these situational, no one really knows why. It's also linked to NSAIDs or aspirin. So you exercise, take NSAIDs, and you get this condition. I think there's another case that I've heard about anaphylaxis-related menstruation from someone in the area. Is that your case, Rob? Yeah. So it's a kind of interesting phenomena, and obviously this is something you really need to nail down the history on, treat the condition, and get them follow-up.
We had one here about 10 years ago. Was a kin student in first year and saw Keith Payton, and she was told to withdraw.
Okay.
And that was the end.
Okay. Did they figure out why? Or?
No, but
Okay.
it was clear, it seemed
Exercise
fairly
induced.
clear, and
Okay.
she had to change programs and
Interesting.
change her life completely.
Ryan, is this any more common in disabled athlete, or is this just a phenomenon that you're...
It's not more common, no. It's just a phenomenon with athletics. Good question. All right, so some other issues specifically with disabled athletes. Pain, phantom pain. So they're often on medications to treat those. Gabapentin, TCAs, opiates. Orthostatic hypotension is also something that's common. Neurogenic bowel and bladder, something you have to pay attention to. Prosthesis problems, so irritation, infection, things you want to look at is the padding, is it a proper fit, are they changing their clothes enough, is it too sweaty, those kind of things. That'll help prevent further irritation, cellulitis, complications from cellulitis. Some things you really want to pay attention to with athletes, so some red flags. Anytime they have a change in motor or sensory function, oftentimes they will have motor or sensory loss, but if that's changed, you really want to pay attention to that. Do they have a compressive lesion, do they have a stroke, do they have a fracture somewhere else? You really want to pay attention to that. And the baclofen withdrawal, again, or in other things, change in spasticity, is it infection related, is it med related? Obviously, in the case, I didn't tell Meg whether it was a change or not, but usually you will have some collateral history, but not on oral exams. So, fever, you don't want to send that home. You want to work that up. So, good job by Chris for not sending him home. Seemingly minimal increases in blood pressure, which I'm going to get into a little bit. And swollen limb with neurologic impairments. What I mean by that, if they have neurologic impairment in that limb and it's swollen, you got to pay attention to that. Is there a fracture? Is there a DVT? You got to really look into that. Okay, anti-doping issues. So I wanted to ask about this. So the list of the prohibited substance is the same as able-bodied athletes. The exception is the therapeutic use exemption form, which we'll use in able-bodied athletes, will obviously be needed to be used much more often because they're going to be on a lot of these medications that are on the list of prohibited substances. So a lot of the 2Es will use. Any other questions about that? Wonder here.
Just listening to some on CBC the other day about the WADA, part of the Paralympics and all that, but they actually, officials for WADA actually come to competitions and they actually look for athletes that look like they're on autonomic dysreflexia. Because athletes will do that on purpose. So they look for people sweating.
That's life.
Come on, man. Yes, you are in fact correct. Thank you. So back to the case. So the patient's got a worsening headache. They're feeling more unwell. Blood pressure, their vitals are going, or their blood pressure's going up, 165 on 95. Heart rate's at 80. Respiratory rate's a little bit higher, a little bit more febrile, still sagging low. So, as Dr. Pringle correctly identified, inadvertently, the case is autonomic dysreflexia. So I've got a couple of slides with words, and then I've got a picture that makes it a lot more clear. So basically, any noxious stimuli below the level of the lesion produces the impulse that generates a generalized sympathetic response. This causes vasoconstriction at the level below the level, at the body below the level of the lesion. The intact spinal cord, then usually descending inhibitory pathways respond to the blood pressure and modulate the sympathetic response. However, spinal cord injury patients are unable to do that, obviously due to the level of the injury. So you have excessive parasympathetic output, lack of sympathetic output, and this leads to the peripheral vasodilation above the level of the lesion, vasoconstriction before. So the vasodilation above the level is the flushing, headache, and sweating. Vasoconstriction below is the blood pressure. So this makes it a lot more clear here than listening to me. So look, one, the full bladder, or stimulus from the bowel, causes an afferent stimulus. That goes up the spinal cord, and then it causes a massive sympathetic response to the peripheral nerves, widespread vasoconstriction. The afferent stimulus is no longer able to travel up the spinal cord, T6 in this case, is where it stops. Hypertension from the vasoconstriction that leads to baroreceptors in your blood vessels detecting the hypertensive crisis that signals the brain and modulates parasympathetic activity, but that is also blocked at the level of the spinal cord, at the level of the lesion. But oftentimes the level of the lesion is below the level of cardiac, so you'll get your heart rate slowing even though you have massive blood pressure. So your heart rate may be 50, 60, and your blood pressure is kind of 200 over 100 kind of thing. It's clear to everyone? Clear as mud? It's a lot more clear than my slides. This is a CMAJ article in 2003. Anyone was wondering what's like that? So, I've already alluded to some of the clinical features. So, bilateral having headache is common, sweating above the level of the injury, nasal congestion, nausea, malaise, blurry vision are all features of this. Blood pressure may be something you want to pay attention to. Chris was looking at the blood pressure, 130 on 85 seems okay. And normally we blow that off, right? But blood pressure in patients with spinal cords may be low, spinal cord injuries may be lower. So 120 on 80, 130 on 90, whatever, may be elevated in that patient, something you want to look at. And in the literature, there's blood pressures of 250 to 300 over 200 to 220 have been recorded in patients with autonomic dysreflexia. What causes it? Precipitant, 75% of the time, is actually a stimulus related to bladder distension. So these patients are at risk for UTIs, kinked or blocked catheter, kidney stone, testicular torsion, anything that's going to cause retention. A lot of the medications that they're on, anticholinergic, antihistamines, opiates, could also cause urinary retention. That's the most common thing. So if you see someone like this, put the bladder scanner on them. What else can cause it? Fecal impactions is second most common. Essentially anything. Any noxious stimuli below the level of the injury. Pressure sore, ingrown toenails have been listed. Multiple sites I looked at, that was on the list, pretty high on the list actually. Fractures, DVT, anything. Any noxious stimuli below the level of the injury can precipitate autonomic dysreflexia. So if you're asked to put a list on an exam, then you should be able to put a list of 30. Which I'll ask you guys to do and send to me later. So treatment. Early recognition is the key. So you want to figure out, why is this person doing this? So look for and treat the precipitant, indwelling Foley, check for kinks, obstruction. Like I said, do the bladder scan. If that doesn't work, then you see are they fecally impacted. And you also want to be careful with doing a rectal exam in these patients, because you don't want to further cause any noxious stimuli, furthering the autonomic dysreflexia. So if you do a rectal exam and do fecal disimpaction, do it with lidocaine jelly. Sit the patient upright, loosen any constricted clothing, drain the bladder, and disimpact if no response and can't find anything else. What do we do with blood pressure? Nitrates, hydralazine, ephedrine, all of those are listed in treating the blood pressure for autonomic dysreflexia. What do we do with them? If we find the cause, we treat the cause, blood pressure, everything normalizes, we can send them home, educate them about their condition. The source is not found, they need blood pressure control, they need admission, and they need a further workup for the noxious stimuli that's causing this. And back to Dr. Pringle was telling us about. So this is a phenomenon called boosting. So they will go, the anti-doping committee, WADA, will go around and look for patients, and they'll often check blood pressures before the competitions, because people are actually intentionally inducing autonomic dysreflexia to help improve their performance, just from the sympathetic drive. So any people are doing things like wearing tight leg straps, poking themselves with sharp objects, and most commonly, over-distension of the bladder in order to improve their sport performance. So this is something that happens. Obviously, it's banned. They will do blood pressure checks before the competition, and just kind of look at them. Do they look kind of flushed and sweaty? In the face and chest, and then nothing below, like something that's suspicious. There's no actual sanctions if you're caught doing this, but you are unable to compete in that event. The other thing is that obviously this may happen inadvertently. Any noxious stimuli can cause this, so people may be in autonomic dysreflexia in their event, but not know it and not have it happen on purpose. I'm not sure. It would still be banned even though it wasn't on purpose. But that's something that's kind of unfortunate for them. So, just back to the case to finish up. Blood pressure still going up, 180 on 100. Look at the catheter, it's like, hey, only 50 cc's of urine in there, and they've been in the department for a couple hours. What's going on there? We have a urine sample. Doesn't make any sense. Catheter's flush. Oh, what's going on there? Oh, catheter's flushed. It's kinked. So, then 500 cc's of urine flow into the Foley bag after we release the obstruction. Patient's blood pressure normalized, discharged home within a few hours. That's it.